Yeah, there is a new software, but we can help with the team viewer to install the program and to assist you in the first
great
test.
We'll do that. We'll do that.
Okay, Asif, do you want to introduce our next speaker? The last session of this meeting is about therapeutic with 2 main points, pharmacology and vestibular rehab. So, Asif?
Yes, Alex, can you please can we see you?
Well, hi, Asif. This is Alex speaking. I cannot start my video. It says the host has stopped the video. Ah, now I can. All right.
Okay, perfect.
Yes, here I am.
Okay, great. So it's a pleasure introducing Alex Tarnutzer, who we go long ways. 2005, first time I saw Alex. It was before, I think Alex was intern, and it was before my internship I met him. So it was like a long time ago. He came to work with Div Z, I think as last year medical student or internship, right? And we met in Baltimore, and then Alex comes from Zurich. He trained in University of Zurich, and he worked in a very famous lab with Dominic Straumann, who it was formerly Bernard Hess and Fokker Hens lab. And then Dominic is now the lab chief, right, Alex? And then Alex worked in Dominic's lab, and then we all frequently go to Zurich. We just find an excuse to go work with Dominic, but actually, truth is Switzerland. So Alex is a physician scientist. He is MD PhD in neuro-otology. He practices in neuro-otology, and he has wide interests, including skew deviation, TMS, many translational basic science research interests, focuses. Lately, artificial intelligence that he will be speaking about next week. Today, for covering something basic and something educational, we decided to go for something more didactic. So today, Alex is going to talk on pharmacotherapy. Currently, Alex is head of neurology in Cantonal Hospital in Baden, Switzerland, and he runs his own neurology department there, running a busy practice with clinical and basic research. Alex, the stage is yours.
Well, dear Asif, many thanks for the kind and very elaborated introduction. It's a great pleasure for me to give this talk today. I'm just going to load my screen, finding the right the presentation. Here it is. All right. So it's a great pleasure to give you an overview about potential pharmaceutical therapies in neuro-otology, and I'm happy to be part of the fine webinar. So let's get started with the presentation. Disclosures, I think that the most important part of this slide really is, I mean, almost all of the drug treatments discussed here are off-label. So please be aware of this, and when you decide to use these drugs, disclose this to your patients and make shared decisions about weighting risks and benefits, and check also the approval status in your country. So topics I'm going to cover today, I will look into drugs in peripheral vestibular disorders, but also central vestibular disorders and oculomotor disorders. And I will show you that there are plenty of choices. So you should not be heading the direction as in the cartoon. So never give up treating dizziness and vertigo and nystagmus. So before really get into things, why is it important to treat nystagmus? It really has a huge impact on vision and gait. So it reduces visual acuity, it causes oscillopsia, it triggers vertigo and dizziness. So resulting really in a decreased stability on gait and increased risk of falls and fall-related injuries. So it really has a significant impact on health. And for example, visual functioning scores are lower than for other visual impairments, including age-related macular degeneration. So it really counts to improve these symptoms. So a few treatment principles. Whenever you have to deal with nystagmus, it's really, really important that you determine the pattern of nystagmus and try to identify the underlying disorder. This will not always work, but whenever possible, really get the diagnosis. Identify comorbidities, because they will going to be important when choosing your drug, including things like epilepsy, ongoing liver disease, and others. For acquired nystagmus, usually first choice of treatment is drug treatment. So it's about identifying the most suitable substance, and that's what this talk is going to be about most of the time. Usually start with a low dose, titrate gradually to one of those 3 endpoints. Either you achieve effective treatment, so you go on with the treatment, or you have to stop the treatment because of side effects, or you reach the maximal dose of medication, however, you do not reach any effective relief. And note again, the use of drugs in vestibular and oculomotor disorders is often based on off-label, non-controlled studies and expert opinion. So let's start with pharmacotherapy in peripheral vestibular disorders. I'll have a look at several disorders. First, let's focus on acute unilateral vestibulopathy, or also called vestibular neuritis. A nice example you can see here in this video head impulse test with a clear loss of function of the left horizontal and left anterior canal. And so this patient for sure needs treatment. And you have 3 treatment goals you'd like to achieve. First, you need symptomatic treatment of nausea and vomiting. You need some kind of anti-inflammatory therapy, and you may possibly enhance central vestibular plasticity and adaptation. So for goal 1, antivertiginous drugs, there's a huge selection, including dimenhydrinate, metoclopramide, ondansetron, and others. Most important thing here is really restrict any use of antivertiginous drugs to the first 2 or at most 3 days after symptom onset. This is really important because these drugs tend to inhibit central compensation, and that's what it is all about. Anti-inflammatory drugs. There it's important also that you start early with a treatment after symptom onset. Based on the seminal study by Michael Stroop and colleagues published back in 2004 in the New England Journal, I placed this scheme here using methylprednisolone 100 milligram per day, tapering by 20 milligram every 4th day. Of course, there were other schemes. I often use a scheme just using prednisone 1 milligram per kilogram body weight over 7 days and then just stop it. There's not much data on comparing different treatment schemes, so it's up to your personal preference. However, please avoid treating those patients with steroids for 2 or 3 weeks or even longer, because this causes many other problems related to chronic steroid treatment. Note also that there is no treatment recommendation for steroids in vestibular neuritis in a Cochrane analysis. The third and probably most fascinating and still, least discussed topic is enhancing central plasticity and adaptation. There are several drugs which have been discussed to have some effect on accelerating functional recovery. This includes Betahistine and ginkgo biloba. Also probably N-acetyl-L-leucine might be a candidate. I can recommend reading Andreas Zwergal's recent review on this. He's very active in pursuing these new treatment approaches. So let's move on to Menieres disease. In Menieres disease, the goal really is to prevent further attacks and, if possible, to avoid progression of vestibulo-cochlear deficits. There are over 3,500 treatment studies on Menieres disease. And here in this table, you see summarized what's the level of evidence for treatment option in Menieres disease. And I would like to draw your attention to those studies which had the best level of evidence, which are intratympanic pharmacotherapy. This includes both the application of steroids and gentamicin. And for these treatment types, there are randomized controlled trials with a clear benefit. Note, for steroids, only 2 out of 3 randomized controlled trials showed benefit, whereas for gentamicin, all 3 published RCTs showed a clear benefit. However, gentamicin is an ablative treatment, so it's usually reserved for those patients which have already severe hearing loss, because this can be a side effect if you apply gentamicin. Much more popular and obviously much more easy to establish are other oral pharmacotherapeutics. And there it's the betahistine, which traditionally has been used and still is used a lot by GPs, but also by many specialists. But today, what's the role of betahistine in preventing Menieres disease? I mean, betahistine is a H1 agonist and a H3 antagonist, and it has a rapid metabolism by intestinal and hepatic MAO-B enzyme. And it has been recently studied in a high quality large trial, which was also led by Michael Stroop's group. And there it was really a lack of significant impact of the treatment group. What they did actually in the BEMET trial, which was published now 4 years ago, they compared 2 different treatment groups with either betahistine 3 times 24 milligrams or 3 times 48 milligrams, and compared it to placebo. And they did not find any change in the time course of vertigo episodes related to Menieres disease in the treatment and in the placebo group. So based on these observations, well, it's not really evidence-driven to use betahistine in preventing Menieres disease. However, discussion is ongoing. On one side, many specialists are still using betahistine, and others, they were saying, well, we're just not having high enough doses, so we need to give higher doses. So there are treatment protocols published with 3 times 96 milligram or even more of betahistine per day. Others have started to use MAO-B inhibitors like selegiline to reduce the betahistine dosage needed. So this discussion is still ongoing, and so far many of us are still using betahistine, but we need more data on this. So next topic I would like to cover briefly is vestibular paroxysmia. So in this disease where you have a neurovascular conflict between the 8th nerve and a vessel loop, usually it's an ICA loop, classic treatment proposed is using carbamazepine or oxcarbazepine in the doses outlined here. And this treatment, although effective, is often terminated due to side effects, and dropout rate may reach up to 60%, as described in the trial cited here. So this underlines the importance of finding other drug treatments which may replace these 2 drugs. And one potential alternative may be the use of lacosamide in daily dosage between 200 and 400 milligram per day. It has fewer contraindications and less side effects compared to the classic treatment drugs, and it has been shown effective in patients that did not tolerate carbamazepine and oxcarbazepine in a small open label trial. Of course, there will be future larger studies needed to really define the role of lacosamide in treating vestibular paroxysmia, but it really may be an alternative in those patients which do not tolerate or which cannot receive classic drug treatment. Obviously, it's much more expensive compared to carbamazepine and oxcarbazepine. So for vestibular schwannoma, it's obvious, well, treatment, it's usual surgical resection. However, surgical resection may lead to sudden vestibular loss of function ipsilegionally. And imagine you'll have to get surgery done on a patient as the one shown here on the right side with a large vestibular schwannoma, and still very well preserved vestibular function in the anterior and the lateral canal. It's only the posterior canal that has a clear loss of function with many catch-up saccades. So these patients will suffer from a sudden and severe loss of function on the left side when getting surgery done. So that's why the concept of vestibular prehabilitation has been brought up, and therefore you aim for a pre-surgical reduction of peripheral vestibular function to ameliorate symptoms after surgery and to improve recovery. This can be achieved by the application of intratympanic gentamicin. It has been established at many places. However, there are no randomized controlled trials published, and also studies demonstrating that this concept really holds true have not been published yet. So this is still a lot of work needed to be done to define the role of the prehab treatment in vestibular schwannoma, but I personally find it a very interesting approach. So let's move on to bppv. We all know how to treat bppv, so why I'm talking about bppv in a talk focusing on pharmacotherapy? It's mostly because of recent publications focusing on the secondary prevention of bppv by use of vitamin D3 supplementation. There are 3 randomized controlled trials addressing this question. And so I think it's worth while thinking about vitamin D3 when treating bppv patients. So one study actually showed that the recurrence rate within 18 months in bppv patients could be reduced from 43 to 14% when bringing serum vitamin D3 levels above 10 nanogram per milliliter. In another study, the combination of vitamin D3 and calcium reduced the risk of recurrence of bppv within 12 months from 47 to 38%, with a number needed to treat of 3.7. So considering that this is a easy treatment, which doesn't have many side effects, it's really recommended based on the current literature to apply vitamin D3 supplementation in recurrent bppv patients with low serum levels of vitamin D3. So let's move on to pharmacotherapy of central vestibular disorders. I'd like to start first with a vestibular migraine. Acute treatment, there's not much difference compared to migraine headaches. You basically use the same drug, so therefore I will not focus on that, but move on to prophylactic treatment. There was a 2015 Cochrane review, which was not very promising. They identified one ongoing study comparing metoprolol to placebo, and they did not find evidence from randomized controlled trials to really answer the question which drugs would be promising for prevention of vestibular migraine. So this is 5 years ago. What has happened in the meanwhile? So there are a few recently published studies on this topic. They focus on various substances. There is one study which compared beta blocker versus SNRI. There was one study focusing on cinnarizine plus dimenhydrinate. There was another study comparing 3 different drugs, venlafaxine versus sodium valproate versus flunarizine. There was another study focusing on acetazolamide, and there was the Provemic trial, which was you comparing metoprolol to placebo. So what can we draw out of these different studies? And how can we implement those findings into our daily practice? So overall, what has to be said is that the study quality was weak to moderate in those studies. There were few prospective randomized controlled studies. There was only one placebo-controlled study. This was the Provemic trial, and this study was terminated early due to poor participant accrual. Overall, if you take those reported findings together, I think that there's the most convincing support for using venlafaxine as first-line treatment in vestibular migraine prophylaxis. There has been shown efficacy in 2 prospective randomized studies. It has a broader treatment spectrum than sodium valproate, flunarizine, and propranolol. And it's, however, still unclear what the best dose is. There was one study saying that the very low dose, 37.5 milligram, was sufficient, whereas the other study actually reported higher dosages between 75 and 150 milligram that were needed. So for your clinical practice, I would say start with a low dose, observe how it's going to be tolerated and how efficient it is, and then increase the dose as much as necessary. At the same time, the data was less convincing for cinnarizine and D-menhydrinate and for acetazolamide. That study actually also had a selection bias and more side effects. So let's move on to cerebellar disease. There's a series of drugs that can be considered. Amongst those, there is 4-aminopyridine, including a sustained release form of 4-AP. There is acetyl-D-L-leucine, a drug in Europe also known as Tanganil. There is acetazolamide. There's also chlorzoxazone. So what's the impact of 4-AP on cerebellar function? It's a potassium channel blocking drug. It increases the resting discharge rate and the excitability of cerebellar Purkinje cells, and thus there's an improvement in the synchronicity of firing rate of cerebellar Purkinje cells. And by the increased activity of Purkinje cells, the GABAergic inhibitory influence on the cerebellar deep nuclei mediated by the vestibular cerebellum is restored. And therefore, what can be observed at the bedside is a reduction of downbeat nystagmus and gait ataxia. So 4-AP has been studied in a series of trials, and regarding treating gait ataxia, it has been shown that 4-AP improved cerebellar ataxic gait due to various disorders, including multiple systems atrophy, sporadic adult onset ataxia, and cerebellar stroke. Similarly, the sustained release form of 4-AP, so-called famotidine, showed a moderate short-term gait improvement. And Tanganil, the dosage of 5 grams per day, resulted in an improved SARA score. So thus, reducing cerebellar symptoms, including gait, speech, and alternating movements. In episodic ataxia type 2, which is characterized by a CACNA1A mutation and recurrent attacks of ataxia for hours, typically also accompanied by mild interictal cerebellar symptoms, including gaze-evoked nystagmus and downbeat nystagmus. Again, the aminopyridines have been studied, and currently the first treatment choice, it's the sustained released form of 4-AP at a dosage of 2 times 10 milligram per day. Well, this recommendation basically comes from the Eat to Treat trial, which has been presented at the AAN this year, virtually obviously, and however is still unpublished. Based on Michael Stroop's presentation from the Eat to Treat trial, they observed less side effects than acetazolamide and comparable efficacy. Alternatively, you can use acetazolamide, which is a carboanhydride inhibitor at a dose between 250 and 1000 milligram per day, or you can use 4-AP at a dose of 3 times 5 milligram per day. For this treatment protocol, actually, the monthly median attack frequency in EA2 dropped from 6.5 to 1.7, and quality of life improved. Thus, there is also a treatment recommendation by the AAN. One topic I would like also to cover briefly is functional dizziness. Overall, it's an overall term for various vestibular-like disorders of somatoform or psychogenic origin, including PPPD, phobic postural vertigo, chronic subjective dizziness. There is a series of open label, however, non-randomized studies addressing this disorders. And what came out of these studies is that it's mainly SSRIs like sertraline, paroxetine, and others, or SNRIs in combination with cognitive, behavioral, and physical therapy that had the best impact. So let's move on to oculomotor disorders. First, I would like to focus on downbeat nystagmus. Downbeat nystagmus can be part of cerebellar syndromes, as we discussed just a few minutes ago, or it can be isolated. Importantly, please remember Purkinje cells, they are GABAergic and potassium channel load, and that's also the rationale behind using 4-AP as discussed before. Here you see an example in a single patient treated with 10 milligram 4-AP. On the left side, you'll see vertical eye position recorded over 35 or 40 seconds with a lot of downbeat nystagmus, which clearly improved 90 minutes after drug intake. So what are the treatment options? One option is the use of GABA-A agonists like clonazepam. However, there are no controlled studies for this drug in this indication, and side effects may be massive, including drowsiness, ataxia, and behavioral problems. So it's more the potassium channel blocking drugs that should be favorized. And there, it's the 4-AP. You already saw a little bit of data. It's actually better crossing the brain-blood barrier than 3,4-D aminopyridine. And it has been shown to reduce downbeat nystagmus, gaze-evoked nystagmus, and postural instability. But in one study, there was no effect actually on patient satisfaction. It has a few side effects, including transient paresthesia, nausea, and headache. And there are a few important limitations. It can be dysrhythmogenic, and it's contraindicated in patients with known epilepsy. So regarding its cardiac side effects, it's important when you first expose the patient to the drug that you actually apply an ECG before and 45 minutes after drug intake. You can also, again, use a sustained release 4-AP. There is a drug supporting its use in downbeat nystagmus. The dosage, it's usually 10 milligrams twice per day. And the advantage of the famotidine is that you don't need any cardiac monitoring. However, again, it's contraindicated in patients with known epilepsy, and it's much more expensive than 4-AP. You may also alternatively use drugs that are activators of calcium-activated potassium channels. And there it's one drug that has been shown to be effective in a single study, which is called chlorzoxazone. It's usually used at a dosage of 3 times 500 milligram per day. And it has been shown to significantly reduce downbeat slow phase velocity and to increase visual acuity. There was also a trend towards less postural sway. Here on the right side, you see actually the mean slow phase velocity at baseline after a single treatment of chlorzoxazone and after, I think, 1 or 2 weeks of medication. Limitations, yes, it's a single pilot study, including, I think, 10 patients. So it's class 4 evidence only. And chlorzoxazone has a few side effects also, including drowsiness, lightheadedness, dizziness, and questionably associated with the drug, also gastrointestinal bleeding. Personally, I think it has the more favorable side effect profile compared to 4AP, and therefore I right now first would take chlorzoxazone and then switch to 4AP if chlorzoxazone is not efficient. Other drugs which have been proposed are effective only in some patients and usually like third-line drugs, including baclofen, gabapentin, and mementin. Let's move on to upbeat nystagmus. Upbeat nystagmus is usually transient, but may be persistent and disabling. It's most often caused by medullary lesions and by thiamine deficiency. And there are obviously different treatment options. If you have clues of thiamine deficiency, well, it's the high-dose thiamine supplementation, at least 600 milligrams per day, better 900 milligrams per day IV. Alternatively, you may use baclofen, or again, you may use aminopyridines. Acquired pendular nystagmus, which is characterized by having no slow phase and fast phase. We actually saw a nice example in Asif's talk. It's usually horizontal and may emerge from focal brainstem lesions, either ischemic or demyelinating, and sometimes is accompanied by palatal tremor. Is best treated with gabapentin. There is a class B evidence for use of gabapentin. It's the mechanism of action. It's most likely the non-GABAergic mechanism of action, including the inhibition of the NMDA receptor, which makes the impact for treating APN with gabapentin. Dosage, there's 2 studies which used 900 milligrams per day, and they showed that it was effective in improving visual acuity and reducing nystagmus. Limitations, again, these studies were small, and there is a series of side effects, including dizziness, somnolence, and fatigue that need to be taken into account. Second-line treatment for APN is mementin. It's a non-competitive NMDA receptor antagonist. Dosage is usually between 20 and 40 milligrams per day. It effectively stopped nystagmus and improved visual acuity in half of the patients. Again, it's a small sample size study with several significant side effects, including dizziness, muscle weakness, pain, headache, confusion, and fatigue. Third-line treatment options include benzodiazepines, valproate, scopolamine patches, trihexyphenidyl, and also tetrahydrocannabinol. Overall, there are better treatment responses in APN related to demyelinating lesions than OPT, which often is treatment resistant. In periodic alternating nystagmus, which is defined as a syndrome with a horizontal jerk nystagmus that shows a spontaneous reversal of direction every 60 to 120 seconds. It's considered that this is caused by lesions of the cerebellar nodulus or uvula, which are important for managing the time course of physiological nystagmus and velocity storage. And so for these circuits, inhibitory GABAergic pathways help to control velocity storage. So based on this knowledge, the drugs of choice were identified, and it's mostly baclofen, which is a GABA-B agonist that is used. There is a starting dose of 3 times 5 milligrams per day, which can be increased. And again, please be aware of side effects, including drowsiness, weakness, fatigue, headache, insomnia, and nausea. Memantine may be added to baclofen, and please be aware of that studies have shown that gabapentin is not helpful in this situation. There are other less common types of spontaneous nystagmus, which is some data on treatment options. This includes seesaw nystagmus and superior oblique myoclonus, which I also lined up here and which can be studied later for those interested in detail. I'll move on to saccadic intrusions, just one slide on that. There's again limited data on therapeutic options in saccadic intrusions, often again single cases or small case series, no randomized controlled trials. And as you can see here, for the different types of saccadic intrusions, including macro square wave jerks, square wave oscillations, ocular flutter, and opsoclonus, different drugs have been proposed and may be used. So this brings me to the end of my talk, and in conclusion, I would like to emphasize that the selection of medication should be made individually, taking into account comorbidities and potential side effects. And also please be aware that sometimes drugs are not the solution to the problem, but its underlying cause. Always obtain medical history and related medication history and related side effects. Aminopyridines, especially sustained release 4-AP, are most broadly used to treat cerebellar diseases and oculomotor disorders, but there may be limited access, especially to sustained release 4-AP due to the underlying costs. The use of drugs in vestibular and oculomotor disorders is often based on open-label, non-controlled studies and expert opinion. This should always be disclosed to your patients. Whenever possible, use quantitative measurements, for example, video oculography or just the patient's iPhone or Android camera to document treatment response. So let's have a very brief outlook. What's going on in the field? There is a series of important ongoing trials, including the Betahistine trials, which looks into the story about improving central compensation by use of Betahistine in acute unilateral vestibulopathy. There's the VESPA trial looking into treating vestibular paroxysmal with carbamazepine. There's another Menieres disease trial with intratympanic slow-release dexamethasone going on. Then there is a vitamin D supplementation in bppv. And there were two trials focusing on cerebellar ataxias, one with fampridine and the other with N-acetyl-D-L-leucine. So I'm hoping for new insights into these drugs in the future. And for those who would like to focus on further readings, I listed up a few papers that are, from my view, very worthwhile reading. And also please have a look at the novel library for neuro-ophthalmological teaching and video content. So I'd like to thank you very much for your attention, and I'm happy to discuss and answer questions at the end of this session. Thank you.
Actually, we can do questions now. We can do questions now. There is one question, Alex. The question is, since most vestibular migraine crises are without headache, don't you think using antivertiginous drug instead of analgesic are more rational?
I didn't get the very last part of the question. Okay. I'm sorry. What is more rational?
Let me repeat. Since most vestibular migraine crises are without headache, don't you think that using antivertiginous drugs instead of analgesics are more rational?
Well, yes. If there's, as I said, I mean, treating acute migraine, vestibular migraine attacks, there's not much good data on it. But well, I would agree. If there's no headache, but nausea, well, I mean, I would focus on those symptoms that are most prominent. Yes, but What's still lacking is like good data on acute treatment in vestibular migraine.
Alex,
There is a
I have
question.
been treating, since migraine, whether it is headache or vertigo, there are two things. This question that he has asked us about symptomatic therapy. So if somebody is having headache, of course you try NSAIDs or triptans. If somebody is mainly getting vertigo,
Yes.
I at least have been treating it with vestibular suppressants, often
Yes.
something like prochlorperazine or something, because you're only giving it once as needed. Then when we come to prophylaxis, in rest of migraine, we do not really use acetazolamide. So why should we treat vestibular migraine with acid? Why not with the usual prophylaxis? So like you wrote, whether it is sertraline or venlafaxine or even amitriptyline. I mean, we have been using all for migraine because most of the patients who get vestibular migraine also have headaches. It's not that they never get headaches. So you would want something which would work. I know there are no trials and there is no good evidence as yet.
Yes.
But,
no, I would not. I mean, I would not.
In Spanish, I will translate for you, which is for how long do you use betahistine in acute vestibular syndrome?
Well, I personally do not use it in acute vestibular syndrome. Betahistine, I do not. I mean, it's something which has been proposed, but I think still needs to be studied and established. I would also not know which dosage really to use. I mean, I would say, in acute vestibular syndrome, especially if it's peripherally caused, it's physical therapy, which is so much more important to my point of view, but I'm sure we're going to hear more in the next talk about it.
So the other question is, what kind of diuretics would you use in Menieres disease?
I'm personally, I don't use any diuretics. I mean, there's no good data on using diuretics in Menieres disease. So, and also the summary slide I've shown, there was low evidence for using diuretics, and I personally do not use it.
Okay.
May I, Alex, that was great. Great summary.
Thank you.
There is a subgroup of patients with vestibular migraine in whom you measure prolonged velocity storage. I think those patients may actually have a channelopathy, and those patients, it's a very few number of cases, do improve with acetazolamide. There's a group of cases that King reported in the last 2 years with really prolonged velocity storage. And they actually also have migraine. So there may be variants of EA2 or something like that.
Yes.
That subgroup really do well with the acetazolamide.
Yeah, I do agree. I mean, there's a selection of drugs which may be considered as a choice worthwhile. I mean, I would not start with acetazolamide in the usual vestibular migraine, but if other treatments fail, and then, I totally agree, Jorge. It's a valuable option to use acetazolamide as well.
So, you had used topiramate for vestibular migraine?
Well, infrequently. Again, it depends on the side effects profile. I mean, many patients do not like, the cognitive impairment.
Yes.
So sometimes they really like the loss of weight. And one argument I sometimes bring up is, any patient with frequent migraine headaches, is cognitively impaired. So, any treatment will actually improve its cognitive skills. So in this context, also topiramate might be a good choice, but it's not my first choice.
Okay. Thank you very much, Alex, for the excellent review. And we will move on to the next and the last talk of this meeting, which is another friend, Dr. Jorge Madrigal from FINO. He was the former president of our last meeting in Cancun, Mexico. He's a neurologist. He was trained in USA in vestibular